This patient needs a hip replacement surgery, and the orthopedic surgeon needs me to provide that dental clearance. They're asymptomatic, but I don't like what I see. What do we do? The surgery's planned to take place in 3 months. Hi, I'm Nudera, board-certified endodontist and author of NuEndo, Rethinking Endodontics. Stay tuned. I'm going to show you how I manage this case. So there are a couple of problems here. An obvious apical lesion associated with that maxillary right lateral, but a less obvious crestal lesion localized to the mesial of the maxillary central. The lesion at the apex of the lateral has likely been there for years, if not decades. We can see the history of root canal treatment and that amalgam root end restoration. But the lesion associated with the central concerns me a bit more. There is an isolated probing depth there with significant bleeding on probing. If we look a little closer at the radiograph, we see a radio-opaque spicule extending from that lateral root surface. What is that? Well, that's a cemental tear. Cemental tears weren't on my radar until the last few years. They never came up in my residency program, or at least I don't recall. I only became aware of them recently when I had an unsuccessful outcome as a result of an unrecognized cemental tear. Now I look for them all the time because they can and do affect the prognosis. The central was not responding to cold, which is consistent with pulpal necrosis, but the presence of that full coverage restoration and the absence of any apical pathology, I would more or less consider the pulp status to be inconclusive. Now I know that inconclusive is not a recognized diagnostic term, but it should be because we see things like this all the time. Asymptomatic teeth, no lesions, and no response to cold. We can't automatically assume pulpal necrosis. So what are we going to do about this case? When we're asked by an orthopedic surgeon to clear a patient for joint replacement surgery, what they are really looking for is for us to let them know if there's anything from a dental standpoint that we feel could cause a significant problem within the next 6 months. Patients are still going to have dental needs after that joint replacement. The orthopedic surgeons just don't want those needs presenting themselves within the next 6 months. So the question here is, will these current findings present any problems within the next 6 months? Now, no one can predict the future, but sometimes we can play the odds. And based on our knowledge and experience, now remember the patient is completely symptom-free. If the only finding here was associated with that lateral, I would consider reviewing the radiographs. And if the lesion had been present and unchanged for years, then the odds of this lesion presenting a problem within the next 6 months pretty low. The concern I have here mainly is with that central. What's going on here is likely active. And although asymptomatic now, it's not responding to cold, and there's that cemental tear. The scenario is much more unpredictable and certainly could cause a more significant issue within the next 6 months. So something like this should be managed prior to joint replacement. The patient and I had a long discussion about the findings and the options. The patient wanted to be as definitive as possible and was highly motivated to keep their teeth. And although the lesion associated with the lateral was unlikely to change, the patient didn't want to take any chances with the upcoming joint replacement. So following a phone call that I placed with the orthopedic surgeon, the ultimate decision by all three of us was to address the findings prior to joint replacement. So here's what I proposed. Non-surgical root canal treatment for the central incisor, root canal retreatment for the lateral incisor, followed by surgical root canal retreatment of both the central and lateral incisor, then surgical removal of the cemental tear followed by guided tissue regeneration. The treatment was proposed to take place over 2 visits. Root canal treatment for the central incisor was advised because of its inconclusive pulp status and the proximity of the 2 root apices, because there would be concerns of devitalization of the central if it happened to be vital. Non-surgical root canal treatment was performed first. The pulp was necrotic, so the sensibility testing was accurate. I used my normal shaping protocols and then the general wave protocol for disinfection. When I was drying the canals, though, I did notice some heme on that lateral surface of my paper points. The canal was obturated with the single cone technique and bioceramic sealer, and the access was closed with a bonded composite resin. The second visit was approached as a phase 1, phase 2 approach, where the lateral was to be retreated first, followed immediately by surgery. The tooth was isolated and accessed. Am I glad that I retreated this first? Just look at that contamination. All of the gutta percha was removed with softener, and the root end filling was pushed apically. The canal was obturated with BC sealer and BC putty in anticipation of that phase 2 surgical approach. The access was closed with a bonded composite resin. A surgical flap was then raised, and the cemental tear was apparent the moment I reflected that flap. So I removed that defect first. There was really no effort to get this thing off, it just flaked right off. The lesion was curetted and the root surface was smoothed and cleaned. I ruled out any fracture with some methylene blue disclosing agent. And then I proceeded to resect the root of both the central and lateral incisor. I removed the displaced amalgam and the apical lesion associated with that lateral. Both the apical osteotomy and the lateral defect were grafted. Resorbable membranes were placed and the tissue was reapproximated and sutured. This is the immediate post-op. This is the 10-day follow-up suture removal appointment. This is 2.5 months post-treatment, and the patient remains asymptomatic with no signs of swelling or infection. At this point, I felt comfortable providing that dental clearance for the joint replacement surgery that was coming up in 2 weeks. The odds are slim at this point that this is going to cause a problem within the next 6 months, and hopefully never again. These scenarios can be tricky to manage, and if the patient was not planned for joint replacement, who knows how long this would have stayed quiet. I have now placed the patient on long-term follow-up. I hope you've enjoyed this case presentation, and I really look forward to seeing you on my channel for future presentations like this. I'm Bill Nudera. Thanks for watching.